Be here today. I'm excited to be able to talk about a subject that I've gotten kind of passionate about over the last couple of years. And so I can't see the chat, so maybe I'll try to breeze through this and then ask questions at the end or answer questions. But if there's anything urgent that people want to stop me for, feel free. Hablo español, pero prefiero presentar en inglés, so I will do that.
Abigail,
Yes, yes.
una sola recomendación, one
Uh-huh.
slowly.
Okay.
Speak slowly so that our interpreter can interpret simultaneously.
Okay, got it. I will
Gracias.
do my best to slow down. So these are the kind of things I was going to talk about today, just some definitions to level set, talk about the symptoms of menopause and its impact on women, and then treatment options. My background, I'm a family physician, I'm certified menopause specialist. I run a practice for the past 2 months here in Durham, but I've also worked in community health for most of my career. So when we talk about menopause, the definition officially is when a woman goes for 12 months or 1 year with no menstrual period. So menopause is really kind of one day, but the time leading up to that, which can last over 7 years for some women, is called perimenopause. And that is often a time of tumult physically and emotionally for women, and when sometimes their symptoms are the worst. And then you have postmenopause, which we often will just shorten to menopause, which is basically after the period of menopause. In perimenopause, again, people can have lots of symptoms. Even if they're still having regular periods, they may have significant difficulty falling asleep, changes in mood or increase in anxiety, brain fog or difficulty concentrating, and then may also start having symptoms of vaginal dryness or discomfort. And then eventually in late perimenopause, they'll also start to have irregular periods, which can be any change from their previous baseline. And then once a woman gets menopausal, again, the periods will go away. The brain fog may continue, hot flashes and night sweats, which you can also have in perimenopause. And then eventually, 100% of women will develop some level of what we call genitourinary syndrome of menopause, which is kind of vaginal dryness and atrophy. And then the other thing that happens as the estrogen levels fall, there's a really significant decline in bone density, which puts a lot of women at risk for osteopenia or low bone mass, or osteoporosis, which is a significantly low bone mass with increase in fracture risk. So many women will spend up to about 40% of their life in menopause, especially as we are living longer. 20% of the overall workforce in the United States is in perimenopause or menopause. So imagine the impact of disrupted sleep and brain fog on people who are trying to work and maybe at the peak of their career. Women with having menopause symptoms have been shown to be 8 times more likely to have difficulty meeting job expectations. And some women, unfortunately, will have up to 20 years of hot flashes and other disruptive symptoms. The average is about 7.5 years. So it's a significant chunk of a woman's career. Again, up to half of menopausal women will have bothersome symptoms of vaginal dryness and vaginal atrophy. It's a major cause of sexual dysfunction, which can cause major personal and relationship stressors. The divorce rate in perimenopause is very high because of unrecognized and untreated symptoms. And it's estimated that Medicare could save billions in the management of urinary tract infections and urosepsis. So basically, infections that lead someone to be hospitalized by treating genitourinary syndrome of menopause. So there's a huge public health impact as well. Just continuing a little bit with some more symptoms, the risk of depression doubles compared to premenopause. At least 40%, probably more, of women experience sleep disruption. Half will complain of symptoms of cognitive decline and worry that they have dementia, although generally these symptoms do resolve, so it doesn't lead to dementia. And then weight also tends to increase over this time period. And once you get to be postmenopausal, 3/4 of women over 60 are overweight. And then another big disruption to quality of life is abnormal uterine bleeding. Oftentimes, women will have very heavy periods such that they develop significant anemia and need to have medical or surgical treatment. And then, so thinking about kind of longer term effects, so I mentioned the bone loss. 50% of women over 50 have low bone mass. And so that's even, often before women hit menopause. If they get a scan done, they'll have low bone mass. And even 1 in 5 will have osteoporosis, even again before they hit 50. Cardiovascular disease is the #1 killer of women, and cardiovascular disease risk goes up significantly after menopause. And dementia, 1 in 2 women will develop dementia if they live long enough, and women are twice as likely to get a diagnosis of Alzheimer's disease as they are breast cancer. And we'll talk about why that's important in a minute. Cholesterol levels rise and insulin resistance increases as well. So diabetes and other things that can lead to increased cardiovascular risk rise. Okay, so that's all the kind of doom and gloom. But then I want to talk a lot about what treatment is available. And one way I've been thinking about this is it's not necessarily treatment. I'm not trying to medicalize a condition, but what we want to think about is what can we do to promote optimal health for women as they age? One option is contraception. So, in the perimenopause phase, women often can still get pregnant, and they may think they cannot because they're having skipped periods, or they think it's been a long time since they got pregnant. So it is important to make sure that there is some contraception if the woman does not desire to be pregnant. And then one of the devices, the IUD, that's placed inside the uterus is very effective for treating abnormal uterine bleeding. So sometimes even women who don't need contraception will get an IUD because they can really treat their symptoms that way. And then sometimes you can use birth control pills as well.
Abigail,
Yes,
the interpreter is asking if you could speak slower.
yes, I'll try. I'm sorry.
Yes, all right.
Okay.
No problem.
Yeah, no problem. Um, and so often, because providers are very comfortable with prescribing contraception, they will move to contraception when it's not necessarily indicated, instead of thinking about just low dose hormone replacement therapy. And so it's not always the best option, but it can be useful. Okay, and so then hormone replacement therapy, we're really talking about kind of 4 different things. So the first is systemic estrogen, and the loss of estrogen is largely responsible for all of the kind of symptoms and things that I talked about on the prior slides. And then systemic progesterone, which is another hormone that's important in the woman's reproductive life. Vaginal estrogen, and then testosterone in some cases can be indicated. And there is no substitute for estrogen. So there are lots of herbal remedies, and there are some prescription medications that have been shown to decrease some of the symptoms of menopause, but none of them will really prevent osteoporosis, decrease your risk of heart disease or dementia. And so I always kind of ask the question of, well, why wouldn't you use hormone replacement therapy instead of why should you? And this is a change from kind of the last about 20 years of clinical medicine, and certainly the way I was trained and the way I practiced for a long time. So systemic estrogen, women have estrogen receptors really all throughout their whole body. So we're used to thinking of it again as a reproductive hormone that's necessary for pregnancy and menstrual cycles. But we have estrogen receptors in our skin, bones, our heart, and our brain. And the symptoms, again, are almost completely alleviated with the appropriate dose of systemic estrogen. It helps preserve our bone mass, protects your heart and brain. And generally, we use the topical version. So it's often a patch, as you can see in the photo here, but you can also use a spray or a gel. And this is safer than the medication that we used to use, which was oral, in which there still are some indications for that. But generally, we're using a topical estrogen. And then vaginal estrogen, because we have so many estrogen receptors in the vaginal area, often we also need to treat that locally. And it is most commonly a cream that we use, although there are also some other maybe less messy formulations. Really significant risk of urinary tract infection, like I mentioned, And if the woman is having any symptoms of pain with sex, then the first line treatment is almost always estradiol cream. And then progesterone. So progesterone is necessary if a woman has a uterus in order to prevent the risk of endometrial cancer from what we call unopposed estrogen, which can thicken the uterine lining. But it also has some benefits of its own, and it's often the first medication that we start in perimenopause. It has a profound impact on sleep disruption. You might be seeing some memes online about kind of that 2 a.m. wake up where women end up awake for, if they're lucky, 30 minutes to an hour, but maybe for the rest of the night. And progesterone is really helpful for this. And it is bioidentical, as is the estrogen. And so it is the same hormone that your body produces when you're premenopausal. Testosterone is not always something that we use, but there's more talk about it recently. When you reach menopause, there's a very abrupt decline in hormone levels in estrogen and progesterone, but testosterone is a kind of more gradual decline from the 30s on. It is indicated for low libido if women are experiencing that, but it also may have some benefits for muscle mass, fatigue, and brain fog. And unfortunately, there's no FDA-approved formulation for women, so generally people have to pay out of pocket for this, but it's not super expensive. And most commonly, we're using a topical gel for that. But again, this is kind of after you've tried and optimized the treatment with the other hormones. So what about breast cancer? In 2001, there was a study called the WHI, which you may have heard of, which came out and showed that women who were on HRT were experiencing higher rates of breast cancer. However, that was different medication than what we typically are using now. So it was an oral estrogen tablet and a synthetic progesterone like we see in birth control pills rather than the bioidentical. And it had a small increase actually in breast cancer risk, but it depends on kind of how you talk about it. It can sound alarming, but really is only increasing risk by about 1 in 1,000 women. And women who were on estrogen alone actually had a decreased risk of breast cancer. So it's a different conversation if you have had a history of breast cancer, but even family history of breast cancer is not a reason that a provider should be restricting access to hormone therapy. And then the other thing that came out of that study was this sort of window of opportunity, and that was within 10 years of menopause or before age 60. And the problem with that is that a 60-year-old is not a 60-year-old is not a 60-year-old. People age differently and have different risk factors, go through menopause at very different times. And so that is still the traditional thinking, but there are people kind of reevaluating that and looking at different studies and more thinking about that age is a number, and really we want to take a personalized approach. The bone health benefits continue even if you start someone outside of that kind of magic window. The benefits to the heart and brain likely do diminish, but it doesn't necessarily become harmful. And then the vaginal estrogen cream is, again, something that really should be offered to every postmenopausal woman, in my opinion. And that does not get absorbed systemically, does not cause any of these risk factors that we worry about. There are some women, unfortunately, who can't take hormone replacement therapy. It's a small number of women, but there are some non-hormonal options. So just wanted to call that out. So if you are having symptoms, know that you are not a candidate. It's still helpful to talk to your provider about what you may be able to use to manage symptoms. And I think I got through this in record time. So this is some thoughts on how to find a menopause provider. The best place to start is your primary care provider or your OBGYN, because again, more and more of us are becoming comfortable with prescribing. And if you can keep your care all in the same place, that's definitely a good thing. And then if you don't have a primary care provider or your PCP is not able to prescribe or you can't get in with your PCP, menopause.org has a list of providers who are certified menopause specialists, and you can find them. through there. And there's also lots of national virtual options I should have put on here as well. Companies like MIDI and Alloy who are really working to expand access to menopause care. So I will stop there and see if there are any questions.